Welcome to this afternoon's webinar on the DSRIP Project Implementation Plan for Project 2A4 Medical Village. Today's webinar will provide you with brief updates on governance and project financing, followed by an overview of the current draft of the Project Implementation Plan, which contains two parts: requirements, steps and target dates, then risks and mitigation. We will not be taking questions live on the webinar today. However, we are taking questions through the DSRIP mailbox, and that mailbox is listed at the end of the presentation. We'll also provide you with instructions on how to send feedback at the end of the presentation. So let's start off with a governance update. You see here the governance milestones that have been set by the Department of Health and are not expected to change. The PPS governance must be finalized by September 30th of this year. Following that date, the PPS will need to establish the clinical governance structure, including clinical quality committees, by the end of this calendar year. Just a little bit on status of governance development. DOH has recently released a document titled Funds Flow and NewCo Requirements. NewCo meaning new company. Some PPSs have been considering establishing new entities to govern the PPS. So in the final week of June, this important document was released, and it explains what is and is not allowable in the governance design. What we now know is that the PPS lead entity, which is AHI, cannot delegate any authorities or responsibilities that are part of governance. We can't delegate without written approval from DOH. What we can do is develop a shared governance model to support collaborative decision-making across the 9-county region. That governance model, what we now know about the model, in order to secure approval from the department, our governance, we need to ensure that all aspects of ownership and control reside with safety net providers. An additional requirement is that governance must be with a not-for-profit organization. So an LLC structure that AHI and other PPSs were entertaining won't be allowable. Some of the governance next steps. In order to achieve that September 30th due date, the AHI is working closely with our own members, our board, and the PPS Steering Committee and Regional Health Innovation Team leaders to look more closely at those requirements and how they impact the options that are in front of us. So there will be a series of meetings in July and August. In fact, PPS Steering Committee and the RIT leaders were invited to this Steering Committee meeting. It takes place on Monday of next week. In addition, AHI has elicited proposals for more legal consultation to help move the legal aspects of governance establishment forward in a timely fashion. We've received responses to our RFP and expect to finalize agreement very shortly. And we are planning to finalize governance by that September deadline. Failure to do so would impact the PPS funding. Just a few notes on project financing before we get into the implementation plan. You see here the finance milestones. By the end of this year, the PPS is required to finalize that financial structure, including the reporting structure and the compliance plan. Here you see an illustration of the DSRIP funds distribution requirement. That same document that I referenced earlier, the funds flow and NewCo requirements document, answered several questions that our CFO and the PPS finance work group have had about developing an allowable funds flow model. You know, one of the requirements is that 95% of the funding flow to or through safety net providers. So here you see a diagram of the flow showing the majority of dollars flowing to safety net providers, including the PPS lead. AHI has approval through the VAP exception as safety net. We may then, in turn, establish contracts with other organizations. So after there's been that first pass, after that first distribution has gone from the PPS to a safety net provider, then that provider can, in turn, contract with an organization as needed to implement projects, including ones that aren't safety net. What you see here is just a few more notes on what we anticipate with funds flow. The PPS will enter into performance-based agreements with performance partners. A performance partner is a safety net organization that is entering into an agreement to share risk with the lead. These performance partners may, in turn, then enter into non-performance-based contracts, so contracts for services that are needed from other organizations in order to implement the project. Notably, the submission of detailed work plans and budgets could be a requirement or a deliverable in those contracted arrangements. And now on to today's agenda, the project implementation plan. First, I'm going to give you a little overview of the plan, and then we'll go into the specific requirements for Medical Village. When you look at these implementation plans, the requirements, that language is language that DOH put forth. Those have been preset by the Department of Health. So while we can't change the requirement itself, what we do need to do is to provide an implementation plan with sub-steps and target dates that show the actions that we need to take to reach that requirement. So the implementation plan is required to be submitted to DOH on July 31st, and what we submit will drive our subsequent reporting. So we want to be careful to hit the right level of detail. We need to demonstrate that we understand the major steps that we need to take and how they interrelate or are dependent on one another over time. So we recognize that when partners look at these implementation plans, they see that it's a fairly high level, and when it comes to a more detailed level, yes, your team, your organization that is taking part in a project will need to create a much more detailed work plan in order to generate a budget and to really allow your management internally to oversee progress on the plan. But those detailed work plans and budgets, I just want to be clear that they're not being sought by the Department of Health or by AHI at this time. In fact, we don't expect them to ever be sought by the Department of Health. They may be required by AHI or a performance partner as a deliverable on a contract. So some questions to consider as you look through the implementation plan today. Just overall, are the steps adequate? Are there more steps that you would add? If a step isn't clearly stated, how would you reword it? Keep in mind kind of that flow of steps and target dates over time. Is there something that needs to precede in time another step and that wasn't quite noted? So really overall feedback is very much welcomed. And you'll see as we get into this one that the Medical Village plan does need quite a bit of detail to be added over the next few weeks, and we certainly hope that you'll provide some if at all possible. So the Medical Village project has a speed commitment of DY3Q2. What does that mean? What that means is that the PPS has already made the commitment that we will meet all of the requirements for all of the projects, all of the implementations of Medical Village, so all partners, all sites, all project requirements will be met by the second quarter of the third DSRIP year. So that date would be September 30th of 2017. Now, we'll go through the requirements, and you'll see a draft of some of the steps and some potential target dates to get us towards that September 2017 requirement for meeting all the steps. So the overall step or requirement is to convert your outdated or unneeded hospital space into an outpatient services center or these other purposes that you see stated here. The first step, we'll break that down into multiple line items in the actual implementation plan. But overall, we're looking for each medical village to have a strategic plan that includes, at minimum, the services that will be provided in that village, the justification for those, the plan for the transition of the inpatient capacity, how the community will be engaged in that process, and any required capital improvements or physical location changes that are needed, as well as marketing and promoting those new services. So really comprehensive strategic plan. When I look at this, I know that a great deal of that information the Medical Village partners have already gone through and provided to us when they submitted their applications for capital. So the one difference with Medical Village than the other projects is that for Medical Village, every Medical Village project has a significant need for capital in order to succeed. So when you submitted your CRFP application, you really had to lay out quite a bit of this information already. So in fact, developing that plan that includes those pieces, I think most of you have already done that. We'll look at those more closely, see if there are some additional steps that we need to take and what the dates would be for those. But I can say that across the partners in this project, much of that much of that detail has already been put down in the CRFP, and we'd be working with each of you on some of these other items that we need to do, such as marketing and promotion, and how we want to handle that. And again, similar to the next step, reflecting that community involvement in the development. We'll work with you with that as a group. So the next requirement is to provide a detailed timeline documenting the specifics of the bed reduction and the rationale, and to specify the bed reduction that's proposed in the project, making sure that it's definitely including active or staffed beds. Keep in mind when you look at this requirement that Medical Village was designed really, I think the Department of Health had in mind large facilities downstate that had significant numbers of beds, that they would be phasing bed reductions over time and really reworking the types of services delivered from that physical space in a significant way. While our project concept, it has been accepted and approved, I think that we just need to recognize when we look at the requirement that this bed reduction timeline for us, this might be very simple. It might simply be, I know we have some medical villages that are decertifying, 5 or fewer beds. So it's not an extensive, complicated timeline. It's really, these are the beds. This is when we plan to make the switch from how they're currently used to how they'll be used in the future. So next, we need to ensure for Medical Village, some medical villages, again, not necessarily the medical villages through the AHI PPS, but the concept was that some medical villages might in fact be hospitals that are decertifying beds and are offering outpatient primary care services in that same space. So if that's the case, you would need to ensure that any primary care providers that were part of the medical village were meeting the NCQA 2014 Level 3 Patient-Centered Medical Home Accreditation by the end of DSRIP Year 3. So if that is the case with your specific medical village, if there is a primary care partner as part of that medical village, we would simply coordinate that with Project 2.a.iv. Project 2.a.iv is the PCMH certification project. So should there be primary care providers as part of a medical village, I'm certain that they would already be engaged in Project 2.a.iv and would have the supports and management they need there in order to meet this NCQA requirement, but we would certainly coordinate and make sure that that is the case. Another requirement here is to ensure that all the medical villages are actively sharing EHR systems with the local health information exchange, Rio Shiny options, and certainly the hospitals that are part of the AHI PPS are all already all Rio participants. We simply need to make sure that as we're designing medical villages, that any new services and other records that are being introduced into that village, that it's part of that system, so that information sharing can meet this standard. Using EHRs and other technical platforms to track all patients engaged in this project. So this is a requirement that applies across, it's really, I believe it's in every project is that you'll use some type of technical support in order to do your patient tracking. The date by which the PPS has committed to reporting on actively engaged patients for Medical Village is the March 2017 date that you see here. So that's the date that we've put as the target for this step. It doesn't mean that we have to wait until that time in order to be able to do tracking. It's just that that's the first time that we would have to report on tracking actively engaged. For this call, for this specific project, I want to make sure that I mention, hot off the press, I just heard from the Department of Health less than an hour ago that a new updated document of refined, revised, actively engaged definitions is expected to be out before the end of the week. And we've had multiple questions about the tracking of actively engaged for Medical Village and how to operationalize the definition we had previously been given. So I'm hopeful that this document will answer some of our questions and help us build that system so that we can track the right types of numbers and them to be comparable from PPS to PPS. You know, the way it was kind of described before, there could be a lot of different interpretations of how you operationalize that. So I think we'll get more guidance on that this week. And another requirement is to ensure that the EHR systems used in Medical Villages are meeting meaningful use. Stage 2, similar to several of these more technological requirements, the steps are largely steps that are being undertaken by the HIT work group and Project 2.a.iv team, but we would simply coordinate with them to ensure that that's all happening. And the final requirement is to ensure that the services that migrate to a different setting or location are supported by the comprehensive community needs assessment. I believe that this requirement has largely been met because you explained in your CRFP applications how the types of services that you would be implementing in the Medical Village tied to a need in the comprehensive community needs assessment. So we'll look back at those CRFP applications and be able to determine you know, what steps need to show up here in the implementation plan. You know, importantly, this implementation plan that's going into the department at the end of July really needs to capture not only steps going forward, but also some steps that we've already taken. So this is, in fact, you can think of this as our first kind of formal report to the department about the steps we plan to take in the future, as well as some steps that have taken place since April. So the implementation period began in April, and you know, looking at that assessment and determining what types of services would be viable for a Medical Village concept are ones that I know each of your project teams you know, already worked on, and we'll simply use this July 31st report to show them that work has been accomplished. Now we'll look at some risks and mitigation to Medical Village. The most substantive risk is the first one listed. There's a substantial need for capital for all 4 Medical Village projects. Normally, when there's a lack of dollars is a risk. You know, the mitigation, the kind of canned mitigation is always to seek another source of funding. Seeking another source of funding for capital costs of this magnitude, we recognize, I want you to know that at AHI we certainly recognize that that's not a realistic mitigation strategy. The amount of dollars is significant, and there simply aren't funding streams for capital. As hospitals that are doing these Medical Village transformations, you all know how difficult it is to secure capital. So we're not underestimating really the magnitude of this risk. That, you know, should the Department of Health, should there be delays in the CRFP award notices, and should funding simply not be awarded, that we really need to revisit the viability of the Medical Village project and work together with you to determine if there is a lack of capital, if there is a path forward. So we would work with you closely on that. Some other risks include the risk of shortages of qualified professionals, difficulties recruiting, hiring, training in order to fill any new positions that are available in the medical village, and the mitigation would be to work with the workforce committee on those staffing needs. Another risk is that we have 4 different medical village implementations, and they're very different. So each implementation has its own needs, and trying to stay on this schedule that the Department of Health has put forward in order to achieve the milestones and thus drive the payment, is going to be difficult. Our mitigation here is to provide strong project management support, and really needing to get together with you in the near future with each medical village on an individual basis and determine what project management and other resources your medical village project is going to need in order to succeed, and then figure out where we can get those, where in the funds flow we can make sure that those needs are met. So we certainly understand, the magnitude of capital projects, of facilities reconfiguration and development and new service lines, and the many resources that you'll need to do that successfully are ones we have to ensure the funds flow supports. Another risk is lack of community awareness of new services available at the village. It's a location. Fortunately, that's an easier mitigation than some. We'll work on media and promotion to ensure that people are aware of what new services might now be available in their community. A couple more risks. Shortage of internal resources. I sort of addressed this in one of the previous risks. We know that in order to make the medical village successful, the hospital will need to consider what additional staff are needed, and we'll certainly work with you on how the DSRIP funding can support especially a lot of those startup costs for the medical village. Finally, risk is that the bed reductions at a given hospital, is there a risk that bed reductions would cause issues where there's lack of space? I feel that in the early phases of medical village, when many of the project teams worked on the question of, is a bed reduction viable at our organization, that they looked carefully at whether or not this would be a substantial risk. Certainly, if the risk was substantial, then medical village probably wouldn't be an option. So I think this is one risk that we had identified, but I believe each team, did some work in the beginning. Particularly, Megan Murphy had just joined AHI at that time and supported some of your development plans. And you really looked carefully at, are there seasonal variations in the need for hospital beds? Would the bed reduction really be putting the community at risk of not having access to needed inpatient space? And if the answer to that question was yes, then we didn't pursue. So I think we're okay with this particular risk. So questions, as I mentioned earlier, we won't be taking questions live today, but please do send them to the AHI DSRIP mailbox, and that mailbox is shown along with the instructions on how to provide feedback. The DSRIP mailbox, DSRIP-AHI at adkhi.org. Send questions, comments, any kind of feedback. We recognize that the time frame is short, but if you are in a position to provide some feedback in advance of our due date to the Department of Health, we would much appreciate it. Use the subject line IP feedback, and be sure to specify which project you are referring to. We are managing multiple projects, and we can route it more effectively if you use that subject line. So you will see on our website the actual webinar that I just went through with you today, as well as a draft of the implementation plan, basically those requirements and steps and due dates. You'll be able to just download that from the website and make some edits there if you like and return it to us as an attachment. If you have feedback that's more brief, please do, again, feel free to simply send an email in the body of your email, your feedback to that mailbox. And with that, I thank you for taking part in today's webinar, and for all the Medical Village partners on the phone, we look forward to getting on to the next phase. We'll certainly keep you posted as we learn more about the issues with the capital funding. I have nothing new from the last time that Lynn Wadley, our CFO, reached out to those of you that have had some capital issues. We've had no new information. If we do get new information, we'll certainly share it with you as soon as possible. Thanks, everyone, and have a good afternoon.